So I'm so glad to be here, and I will give you a little background. So I was a high school college athlete, but what's even more interesting that I don't put in print is the way that I started working in optometry is I actually like made up and fabricated that I wanted to go to optometry school to these two optometrists that I worked for because I needed a summer job really bad when I was 19. And so I sent this letter. I was like, I'm really interested in going to optometry school. I'm so excited. And I've worn glasses since I was 10, but I had zero interest. I knew I wanted to do something in healthcare. And they hired me. And it was just, it was one of those things that I fell in love with it within the first week. And I transferred to Tahlequah like 2 weeks before school started, like Stephanie read. I'd never been there. I drove home from Pennsylvania, like to find an apartment, dropped all my stuff off and started school 2 weeks later. Never met anyone, never even been to the town or the school. And all these years later, here I am. So sometimes, fate intervenes and here we go. So we're going to talk about cosmetometry. So I am in private practice in Oklahoma. And, Dr. Zamora talked about having different I call it pillars. So, and this is real life, right? And who doesn't love Baby Yoda? He had to make it into the slide deck. So pillars of our practices. And because I'm in private practice, I'm always looking at how do I keep my house on all of these pillars so that if one of those pillars gets yanked out, my house doesn't fall. So I practice primary care optometry, but I also do a lot of specialty contact lenses. We have a dry eye center of excellence. And then the last piece that I've done in the last 5 years is aesthetics. So because I'm in Oklahoma, I'm really fortunate to have a really broad scope of practice. So I've been doing neurotoxins. I have laser where I do non-ablative procedures. I do ablative procedures. We do RF. So we're going to go into all of that. But my good friends from Tarsus actually taught me something this weekend that I hadn't really thought about directly, but I love this analogy. So when you walk into the room with a patient, and I have students, I'm an adjunct faculty member at NSU still as well. So I always teach them when you walk into the room, look at the patient, look at how they sit, look at, do they have a funny head tilt? What's happening there just in their posture? Patients will sit funny like this, even if they've got blepharoptosis or they'll make these modifications. I had a kid that was 19 that came in for his contact lens exam, but he had a really funny new head tilt. And I asked his mom about it, and she's like, he's just been studying a lot. And I asked him about it. And he's like, I don't know, I hadn't even really noticed. And so I set him up straight and did a cover test, and he's got a 6th nerve, and he had a 3 centimeter aneurysm. So those are the things that you will pick up those subtle changes for head tilts. But the other one is when sometimes we get really focused on cornea and ocular health. And we've heard a lot about dry eye today, which I have a dry eye practice. But guess what? There's a whole house in front of that cornea, right? So lids, brows, everything happening, lashes. That's what I consider, the porch of the house, right? If you go and you decide, okay, I'm going to buy a new house, and you look at the porch and all the stuff on the front, and you don't look at any of that, you just walk in the front door and you're inside the house and everything in there looks amazing, but the porch has fallen down, one the floorboard you've stepped through. So we have to look at the whole house before you just walk into the door. And so look at brows, lashes, and we'll walk through that. And we'll talk more. But of course, how we see ourselves and what's happening in real life when we look in the mirror sometimes is very different than what we think about. And guess what? So do our patients too. So only 11% of patients have a conversation with us about what they're putting on their eyes and around their eyes. We are the only profession in the healthcare community that has a microscope looking at eyes, right? That's a huge opportunity to talk to patients about what they're doing. And because they're sabotaging things they don't even realize. And sometimes we don't even realize. So we're going to walk through that. This was a poster that was presented at Academy in 2016, which is where that stat came from. Do you ever talk to your ECP about how to take your makeup off? Are you asking questions? I mean, how many people in here, when someone says, hey doc, which mascara should I use? Are you super comfortable with that question? Or are you like a deer in the headlights like I used to be, right? He's like, no, I don't know, right? But patients ask these questions, and I wanted to have better answers when they ask those questions. And we'll talk through that. So I want us to leave this room thinking differently. When I think about what is comprehensive eye care, that has changed dramatically since I started practicing 20 years ago, right? Yes, everything we do is about vision and keeping the patient seeing well, but there's a lot that goes into that. And I want patients to feel well as well. There's a whole person behind that visual system. I mean, think about what we do now. We've got myopia management. We're going to talk a whole lot about cosmetics. You know, how patients see and perceive themselves. It's so much more than just the visual system and helping somebody see better. And so that comprehensive eye care moving forward, I want us to start to think differently. And we're going to talk about cosmetic offenders. We're going to talk about habits. You know, like I said, I do neurotoxins. We'll talk about that. We'll talk about non-invasive procedures that people can do. You know, we've heard about NEEK and the drops there, minimally invasive procedures that people can do. And then of course, we've got surgical procedures, blephs, et cetera. And we have this skill set that we should be leading these conversations. No one else in the country has the skill set that we do about the eyes and all of the things that we're looking at. We just got to think differently and recognize that we know a lot more than we think we do. So when you look at the global cosmetics industry, $440 billion by the year 2026, that is a huge number. Women in the US spend approximately $3,800 a year on makeup, which is why that meme is up there. Where's all your money? It's on my face. Now this is the takeaway. 15 billion will be spent on global influencer marketing in 2022. And 82% of women believe that social media drives trends. How much does a social media influencer that's not a physician know about makeup and eye care? This much. And that's where they're getting their information. So you and I have an obligation to the patient and to the public and to the people doing this to start to have these conversations. When you look at blue light, how many people in here talk about blue light with their patients? Yeah. What do we talk about? Cataracts, macular degeneration. We don't really know exactly what that's happening, but we think there's a pretty good issue there in the future. Talks about circadian rhythms. That's been proven, but it also has effects on skin. And so when everybody during the pandemic and before, I mean, the average person pre-pandemic was on a screen 11 hours a day. I'd hate to see what it is now. I could look at my phone and look at screen time and be wildly shocked. It also leads to pigmentation, swelling, redness, other skin problems because it's short wavelength blue light. It's not just macular degeneration and cataracts and circadian rhythms. It's also the skin around our eyes. So the skin on our eyelids is 0.5 millimeter. The rest of the skin on our body is 1 millimeter. The skin here is very different. It ages faster. So we don't want to do things that age faster. People don't like that, right? And we're not Benjamin Button. We can't go in reverse. So when you look at what happened in 2020, and here's another reason, I'm giving you all these reasons to have this conversation. Because when you look at lipstick sales, no shock, they dropped by 28%. Nobody's going to waste lipstick behind a mask. I mean, I have 2 daughters, 11 and 8, and I still wear my lipstick. And my younger one's like, why are you doing that? You're putting a mask on, like, it's such a waste. And I was like, I don't know, it just makes me feel good. But apparently the rest of the country agreed. But eye makeup sales went up 204% because this is the only part of the face that showed, right? So even more of an obligation for us to have these conversations. So what exactly is a cosmetic? Sometimes it's probably more things than we think about. It's anything that's rubbed, poured, sprinkled, or sprayed on the body. We use it to cleanse, we use it for anti-aging, and we use it to make ourselves look better or enhance, as Dr. Zamora said. So the risks with these cosmetics are they're carcinogenic, they can be endocrine disruptors, they can have neurotoxins. In the right place are great, but in the wrong place and chasing too many things messes with the blink reflex, and it can induce dry eye or make dry eye worse. Reproductive toxins, and what's it doing to the ocular surface? Contaminating the tear film, irritating the cornea and conj, stressing the ocular surface, causing meibomian gland dysfunction, contributing to meibomian gland loss. Once those are gone, they are gone. We don't remake those, right? And causes tear film instability, which is the very definition of the TFOS-DUS2 loss of homeostasis on the front surface, and tear film instability, cause or exacerbate dry eye. So if you're looking for, and as Mark said, when you look, you'll find, when you start looking for this and having these conversations, especially when you treat a dry eye patient and they're at home doing things that are sabotaging what you're trying to help them with, then it can become a little bit of a vicious cycle. So the average woman exposes herself to 167 chemicals a day, which is crazy, right? No one has, this is the most disturbing statistic. And when I tell patients this, they are shocked and horrified. So the FDA has not touched the Cosmetic Act since 1938. You can put whatever label you want on anything you want. If it says hypoallergenic, means nothing. If it says fragrance-free, means nothing. It's in everything: lipstick, blush, foundation, eyeliner, eyeshadow, mascaras. So you can't teach people a brand. You can't teach people use this, use that, but you can teach people ingredients to avoid. And that's what's in your handout, because a lot of it I can't even pronounce. But, and it's interesting. I mean, I have patients all the time like, oh no, I paid like $60 for this mascara. It's Dior show. It's amazing. Just an example. And I'm like, yeah, you paid for that haute couture label. That's all you paid for. And so the second piece, when I tell them this, they're also shocked and horrified, is 11 chemicals in the US are banned. When you go through the European guidelines, 1,328 chemicals are banned. I mean, that's crazy. And so these are conversations I have with all of my patients at this point, because we can obstruct meibomian glands. I mean, you've seen patients like this, I know, where, we've got junk just lining the meibomian glands and clogging those up. It desiccates tear film, and then it, of course, increases the inflammation, inducing evaporative load of patients with OSD. This came from the DEWS 2 report, and what we're looking at is when you've got, all of that happening with all of these things we put on the front surface, we're causing problems and we're triggering that whole entire cascade. I mean, it's all over. So let's dive into Beauty and the Beast. I like to ask a lot of questions. And when I ask questions, then it makes this conversation much easier for my comfort level. And patients are always pleasantly surprised and grateful when we start having these conversations. I've never had anybody that was like, why are you talking to me about this? And I ask, what kind of makeup do you use? How do you take it off? That's a big key one. Do you take it off every night? I mean, there's a lot of patients that you see, right? You're like, man, that's been on there for like at least a month. Come on now. I mean, I know that smoky eye is like, better the next day, but no. What kind of mascara is best? That's when I get commonly. And extensions, so used to, I'd have like maybe 1 or 2 patients like a week that had extensions. It's like every patient, right? Like every patient has extensions. And so my next question when I see those is, how do you clean them? And the most common answer is, oh, I don't do anything to them. I don't touch them. I'm not supposed to touch them. It makes them last longer. Ew, what the heck is happening in between that skin and the base of that lash? We've been talking about Demodex this morning. A whole lot of little creepy crawlies are 42-inch screen. And then they're like, oh, yes, that's what we're doing when we don't touch your lashes. I have a good friend who is an amazing optometrist in Oklahoma. He was the first OD in the country to do PRK. And I asked him this question about, cosmetics. How come? He's like, I just tell my patients not to wear it. And I was like, oh, how's that working out for you? Right? And he's like, it's fine. I was like, okay. So because 44% of women say, if I can't wear my makeup, I feel I can't do this. I have negative feelings, right? And bottom line is they're going to do it whether we want them to or not. So we have to teach ourselves and our patients and each other, what we can do, what's safe, what's safer. So when I got into all of this and really started to pull like this aesthetic thread, I read a book by a plastic surgeon that's based out of Chicago. And he had this whole chapter on Disney, because we look at what people aspire to be, what people look at as beautiful, what's considered beauty, and this whole chapter came up and I never thought about it until I started pulling all the pictures. you know, and the first Disney princess, I think, came out in like late 1940s, early 1950s. It's exactly the same. So they all have these like doe eyes with the extra lashes at the edge. You know, in our youth, our faces are upside down triangles. We're wider up here, narrower down here. And, you know, we've got full lips, and the only difference between these princesses is their hair color and their dress and their eye color, right? The face shape and all of the features, exactly the same, which I think is fascinating. And when you start talking about and looking at patients, and Dr. Zamora touched on this, you know, you have to look at the brow and the lid and look at all of that whole piece. And so let's just start with brows and work our way down and in. And brows are really trendy. And so I started in 1920. And then I rolled us all the way forward to 2021. And it's just fascinating that what it was in 1920 was also what it was in 1990 with Kate Moss and Christina Aguilera around, you know, early 2000. And then Marilyn Monroe in the 60s, you know, Twiggy in the 70s. And then, you know, here's Brooke Shields in 1980. And then here we have today, which is pretty much what Brooke Shields looked like in 1982. So they're trendy. And people will do, you know, the biggest thing right now is microblading. Yep, exactly. Yes. And so guess what happens when you know, poke pigment into your skin? So a couple of things. You're desperately trying to fill in your brow to make it look fuller. You kill the hair follicle in that process a lot of times. And then you can have horrific allergic reactions like this person did to the pigment. I mean, when people get tattoos, you know, the red ink color is typically what most people are allergic to, but you can have those kinds of allergic reactions to any ink color, but it's a tattoo and it doesn't stay. It's not permanent. They have to have this redone. It turns like a weird green-gray color after about 3 to 5 years. So these trends that people do, I'm like, don't do anything permanent, draw it in. I mean, I draw mine on every morning, you know, because guess what I did in 1990? I wanted to look like Kate Moss. So I plucked the heck out of them and now they don't grow back. And so now I have to draw them on. So nothing that's like permanent is what I teach patients. So I'm not a huge fan of microblading. So let's talk about these lashes and these extensions. So the other thing people do with these extensions is they make them like super long. I mean, like the lashes come in before the person does, right? They enters the room and you're just like, hello, spider. Supernatural. But here's what's happening. Like our lashes are on our front of our surface. Our lids and lashes protect the front surface of the eye. That's their job. When you make them an extra length, and ideally it should be 1/3 of their eye width, when they're longer, now you create a vector. Now you've got, instead of pushing stuff off, you attract stuff to that front surface. So it's physically not the way that it should be. So there's other ways to get lashes besides just extensions. We can do, you know, just glue on ones in a whole strip. We can do like little glue on ones that go on the edge that look more like the Disney princesses. The glue is typically the problem because it's loaded with formaldehyde and latex, which both are bad on the ocular surface. And then you can also do like the magnetic ones. So there's eyeliner that you put on first that has iron oxide in it, which leaches onto the front surface. And then you put little magnets to that little lash. I had a patient that did this. Thankfully, she only did it to one eye because guess what happened when she went to take the magnet off? All of her skin came with every piece of that iron oxide as she peeled it off. So those are the things that can happen. So here's what I tell patients. If you're going to do this, look at the glue ingredients, make sure they don't have latex and formaldehyde in them. Do a patch test like on the inside of your wrist and make sure you're not allergic to them. Use the individual lashes on the edge instead of a whole strip. Take breaks and don't make them look like, you know, tarantula from the South American border. So extensions, and just in case you don't know, 1 to 3 hour process of gluing these things on to each anatomic lash. So when you're at the microscope and you're looking at lashes, and we're going to talk about why we should do that for multiple reasons, look at the base of their lash so that you can see where that extension adheres to. And they have to fill and redo these every like 2 to 4 weeks. And the glue, solvents, and the fragrances, I mean, you can tell on this picture. Did I just click that off? So on that picture, there's going to have stuff winding up on the front surface. And I've had multiple patients that wind up with this. So when you start looking at complications, 73% of patients have complications with extensions. That is a huge number. Itching, redness, pain, lids feel heavy, contact dermatitis, toxic conjunctivitis, conjunctival erosion because they're so heavy, and allergic blepharitis. And so they'll come in, they're like, I look like this. What do I do? And I was like, take the extensions off. And they're like, what else can I do? I'm like, great. No, they don't want to. So now we got to do a steroid to calm all that down. I mean, I can see them from across the room. It's just frustrating. So glue adhesives for these formidable formaldehydes are what are in these. So I have these listed because, again, I can't pronounce those, which is why that's all on your handout too, so that patients can look at their ingredients. And they'll have mechanical consequences to these. I mean, lag ophthalmos during sleep, collection of bacteria in between the base of that lash and the bed, constraints to physical hygiene because they get told, oh yeah, just don't clean them, you'll the glue will come off earlier. And then that base of that lash can actually calcify, which can cause corneal erosions, corneal abrasions, and then there's preservatives that we don't want. So good practices with these because patients are going to wear them. Glue ingredients, look at those. Take breaks from them. Don't wear them for 2 years, at a time. Clean them with hypochlorous acid because that won't affect the glue. You can spray that on and use a little brush at the base, right? You can do tea tree foam, not oil, because the oil will is a solvent and it will take them off. So we don't want to do that because they'll be super upset with us, right? And I've had some wins in this category and I've had some epic fails still. There's more work to be done. I had a patient that I told her, I was like, this is how you need to clean them. We looked at the pictures, did all this. And as she's walking up front, I hear her tell my technician, well, that sounds okay, Dr. McGee, but I better ask my lash girl about all this. And I just wanted to like die inside, He's like, man. So when we look at patients and we think about doing comprehensive eye care and how we look at patients, look at how they're sitting, look at their posture, look at head tilt. As you're having a conversation, start to look at how they use the muscles in their face. And then when you're behind the slit lamp, when you are looking at them, make sure that you have them close their lids when you look. And we're doing that for a couple of reasons. But collarettes and Demodex are much more common than we think. And if we don't have patients, this patient is looking straight on the left. And even when she's looking straight on and we're lifting lid, you still can't see the base of those lashes, right? But look what happens. This is the same patient. When you look down, now there's a whole story hiding underneath there, right? That we would have missed. So this takes a second, maybe 2 seconds at the most, but tells a very different story for that patient. So when you're doing your slit lamp exam, have patients look down and lift so that you're looking at the base of those lashes, because TP03 is coming. We're going to have a different way to handle this and treat this. And so if you start looking for it now, you'll be shocked whenever you start doing this on Monday, because I know you guys are all superstars. You're going to start doing this on Monday, right? Yeah. You're going to be shocked at how many people have this going on. And then do like a little experiment, have them look straight ahead and look and see, wow, I would have missed that. Eyelash, perm, lash lift, and tint. So I'm a child of the 80s. I have stick straight hair. And of course, we always want what we can't have, right? So I put a perm in my hair to make it curly. It's the exact same chemicals. I mean, and I remember sitting in the chair for like 2 hours with that, and it would like sear like every nostril hair because it's so strong. They use that same chemical to perm and create curl and darken lashes. And you can see on all of this, like all of those chemicals are right at the surface. So when patients ask me about this is a hard no, absolutely not. We can talk about extensions. We can talk about, putting lashes on. That is okay with guardrails. This one is always no. And I have had patients ask me that and they're like, okay, if you say no, I'm not doing it. So serums, let's talk about that because lots of patients are doing this. Latisse is the only FDA approved because it has, what do we know? Blepharoptosis 0.03%, right? How many of us treat glaucoma? All of us, we all know that this works, right? But here's what some people don't know. There's a synthetic prostaglandin called isopropyl because it's synthetic. You do not have to go through the FDA. It doesn't have to be labeled. So it's over the counter, right? So patients will buy these serums, dozens of them on the market. And what they don't know is what you and I know, all the side effects of prostaglandin can cause. So I make them show me their product and we look for that ingredient because I can promise they will be very unhappy when they melt all of their fat and they wind up with, ophthalmoptosis and involution of dermatochalasis, not to mention meibomian gland dysfunction and hyperpigmentation, redness and itching, because a little of this is good, more is better, right? That's what my patients always think. And they're again shocked that, oh, I didn't know this could cause a problem, but it's because it's over the counter. I'm like, yeah, Tylenol is over the counter too. And if you take a whole bottle of it, you're going to have problems. So these ingredients are really important. And then there's blepharopigmentation, which is where we're tattooing. We talked about doing brows with microblading, but this is on the eyelid. So guess what happens when you punch through the skin right there? What lives right underneath that? The meibomian glands. So now you just dump tattoo pigment and a needle into your meibomian glands, which will destroy them. And I can't even tell you how many patients I have that are in my dry eye clinic that we are doing lots of things to help keep them comfortable because this is what they did years ago. And I put permanent in quotes again, because it's not permanent. They have to have it redone like every 3 to 5 years. And they desperately wish they would not have done it because their dry eye is so bad. So let's talk about mascara. Just mascara alone is $1 billion product. And we do have an Cosmetic line available, which you all have samples of in your swag bags from Eyes Are the Story. And we'll talk about that. And then I've had plenty of patients just like you, I'm sure, we wind up on the triage schedule because we were driving down the road or we were doing something at home with the mascara brush, right? And it's like, you can see it looks just like that. So it can be mechanical or it can be a chemical problem. And then I still have, heavens to Betsy, I still have patients that use a straight pin to separate their lashes. I'm like, what are you? And I had a patient, she's like, I knew you were going to get on to me. I knew I was going to get in trouble. And I was like, well, yeah, it's a needle next to the front of your eye. What are you thinking? They make these really cool things called an eyelash comb. Like it's plastic, it separates the lashes. Like go buy one of those. So eyeliner, it will migrate places it's not supposed to be. They tight line, meaning that they put it on the wet side. So, and I'll show you a different picture that's better of, okay, when you see eyeliner looking a certain way, don't put it there. And I know a lot of people want to put it on the inside because they actually think it makes their eye whiter and it makes it look bigger. It doesn't, it actually makes your eye look smaller. So is due when you see that behind the slit lamp and they've got eyeliner on the wet side, because now what do we put on top? What sits right underneath all that eyeliner? The meibomian glands, right? So this is my favorite. Like this is me like trying to put makeup on. How to do smoky eyes in 8 simple steps. Yeah, it's close enough, right? I'm just making sure you guys are still awake. But the other one, it really is me. I mean, I'm trying to put eyeliner on and it's complete like disaster. So what I love about Eyes Are the Story, so she's got the cleansers, which is what you guys have in your kits, but there's mascara and there's eyeliner, and the eyeliner is like a Sharpie. I mean, if I can put it on, anybody can put it on and like create like a really nice wing. It's really, really good. And it comes off. And the mascara is great because it comes 3 to a package. So not only does it not have bad ingredients, but it teaches people to throw it away faster, right? Because guess what else is happening? Every time they put that on their eyelid or on their lashes, what's living at the base of those lashes? Demodex, staph. Oh, let's dunk it into a dark tube and leave it. What's happening inside of that dark tube? let's do it again the next day. And the next day, oh wait, this is 6 months old. Not a problem. Gross. And so when I explain it that way, they're like, oh yes, I'll take the 3. Yeah. And so I love it. And so you can see it here, that nice, like it really is like a Sharpie. It's so easy and it doesn't migrate. Looks the same in the morning as it does at night. But I do carry this in my office because patients they do ask, what should I carry? And this is one is very easy for me to say, this is what I recommend. You can do it on your website too. Taking eye makeup off. This is a big one because what a lot of patients that I found, and before I knew better, when I was doing procedures, is I would take patients' makeup off with those Neutrogena wipes. Guess what the preservative is in those? BAK. Who said that? Yes. You get like an extra spritz. BAK at like 1,000 times more than what you and I are used to. And we know what that does to the front surface. So no more of those. And that is what's in your kit. So those towelettes that are in there are amazing. But there's lots of ways. Step 1 is taking it off. And then 2, investigate different ways to take it off and teach your patients about that. This was a study that came out in September of 2020. I will let you read it. It's around tea tree oil and meibomian glands. I think it's good to go explore that. That's in your notes. Clean the makeup brushes like at least once a week. Same thing with like mascara that we talked about. Every time you put that on your face, bacteria wind up in there. You can get bad staph infection. And I mean, I'm guilty of this. When I started putting this lecture together, I was like, oh golly, how long has that foundation brush been in there? So look past all the marketing hype, teach people that, and then do not memorize or try to learn all these ingredients. Use that handout that's in your book and teach people that. And again, like I can't even pronounce half of that stuff. If you want to carry medical grade skin products, that is great, but do your homework because a lot of these medical grade skin products that are very expensive have very high offenders. So do your homework and look at the ingredient list. So top 10 ocular surface beauty blenders, waterproof eye makeup is huge. Do not, that is a hard no. No on the waterproof, it leaches, all kinds of things on the front surface. It's really hard to get off. We talked about eyelid tattooing, extensions, tinting, the gross serums. We're going to talk about Botox here in a second. Loose eyeshadow and like glittery eyeshadow is also bad because what makes it glittery, and if it's loose, is it's ground up mica typically, which is like stone. So it builds up in the meibomian glands when you've got little pieces of, or meibomian glands aren't meant for little pieces of stone to be in there. And then retinol products will decimate meibomian glands, and sharing makeup, of course. And so I talked to patients about this when I would see they would wear makeup, but now I have this conversation with girls starting about age 8 or 9, so that they see me as the expert, not whoever they're following on Instagram or TikTok or whatever nonsense is online that they're following. So they're like, oh wait, Dr. McGee said I shouldn't do this. So I'm starting these conversations much earlier than I used to. And then there's offending agents. You guys have that list. So I like these 2 apps, Think Dirty and EWG. It makes it really easy because you can just scan the QR code and it will pop up and say, it'll red flag the bad stuff, yellow flag, this one's, maybe have some problems. And then, green, you get the green light. So we know lotions and potions can cause all of those things. So what are the right questions? What can we ask that makes patients comfortable and doesn't, make us uncomfortable? So I ask them, I'm like, wow, man, you got long lashes. Those look amazing. What are you putting on there to make them look like that? And then they'll say, oh, I'm using blah, blah, blah. And I'm like, let's look at that ingredient list. And then how do you clean your extensions? If they don't have makeup on, I ask, do you wear it? How do you take it off? Do you sleep in it? And then I go into the ingredient part and all of that. Do your eyelids bother you? That's my favorite one. When I see someone that has blepharoptosis or dermatochalasis, do you want your eyes to be more open? That's the question that I like to ask patients around Upneek, because when I ask it in that way, they're like, well, yeah, who wouldn't want their eyes to be more open? And it gives us an opportunity to say, this is something that you might want to try. And we sample it in the office when they don't have any contraindications, which we just make sure their blood pressure is normal and that they don't have any other medications they're taking that would interfere. My favorite question is around eyelids and skin cancer. So remember we talked about the skin on our eyelids is a lot thinner. It's also the most common place in the body for skin cancer to show up. Why is that? We'll get to that. And then look at where they place their eyeliner. So here's the thing. What the question that we should ask ourselves after we ask all of these things to our patients, but if we aren't comfortable still with that, what happens when we see these things and we don't say something? What does the patient then assume? That it's okay, right? Dr. McGee saw this. She didn't say anything, so it must be okay. I'm just going to keep on doing it. So that's why these conversations are so important. Do not be intimidated by these. You guys are brilliant. I've given you lots of good questions there. Start using that tomorrow. So what should we recommend? Water, water, and more water. 75% of us walk around chronically dehydrated. Salicylic acid is okay in cleansers. Hyaluronic acid attracts water at about 1,000 times its weight. Oils, coconut oil is benign. I'll let you read that tea tree oil study. Caffeine is great because it's a vasoconstrictor and it'll take out puffiness. Alpha lipoic acid, UV protection, and sleep. We're also chronically sleep deprived. I am really sleep deprived after being at AOA this week, but all good. So we talked about sunscreen and why people have more skin cancer on their eyelids than anywhere else in the body. So this was a study that came out of Duke that looked at the why. So these were cosmetic surgery patients that were told, put your sunscreen on and then we're going to take a picture of it so we can see where the sunscreen is. Guess what? Nobody puts sunscreen on their eyelids, right? Why? Because it burns. So every single patient looks like this. So if they don't wear sunglasses, which you and I should be talking about to every single patient, right? Because we know it's bad for cataracts and macular degeneration. But this is the piece when I tell patients when I'm looking at their lids, I'm looking for any lumps or bumps because skin cancer is really common on your eyelids. And you don't put sunscreen on there, do you? And they're like, well, no. And I'm like, it's completely exposed if you don't have sunglasses. And it's just, they're just shocked. And so not only has this helped my patients, it's also helped my optical because now we're buying some good sunglasses because we know bad sunglasses are actually worse because if they don't have UVA, B and UV, A and B in there, now the pupil's dilated behind there and now we got more stuff coming through. So bad sunglasses need to go in the trash, good sunglasses on our face. This is a sunscreen that I carry. It's SPF 50. I have zero financial whatever with this company, but they're great. It's not expensive. The ingredients are good. It's, titanium oxide. It's not oxybenzone. That's the other ingredient that's bad. That's the chemical sunscreen that shows up in your bloodstream within 15 minutes. So this is the one I carry because you can get it in clear, but you can also get it tinted. So I don't wear makeup anymore. I just wear my sunscreen and it's great. One less thing I have to do in the morning. So develop all of those pieces. What time is it? Okay, perfect. So let's switch gears for a little bit. So I told you that I do Botox in my clinic. We have IPL. We're doing laser procedures. And I also have radiofrequency. So when you look at top 5 cosmetic surgical procedures over the last 20 years, number 4 has been blepharoplasty for the last 20 years. So that's another reason why you and I are having this conversation and we want to expand these conversations. And then the top 5 cosmetic minimally invasive procedures are Botox, fillers, and then 5th is IPL, which we are using not only and have used in derm for 20 plus years to help skin, but now we're using it for meibomian gland dysfunction, right? And so these are all pieces in this cosmetic industry that you and I are now doing in our clinics. So non-invasive are going to be radiofrequency and IPL. So when you do all of these procedures and you're like, which one do I do? What works for what? How do I know? Just think of what you're trying to target. So with any of these, we're targeting chromophores. What's a chromophore? So water is a chromophore, pigment is a chromophore, oxyhemoglobin is a chromophore, as is something exogenous like a tattoo pigment. Those are all chromophores. So RF is targeting water. So it's great because you can tighten skin, but you can do on any skin type. Doesn't matter because your target is water. So you can do non-surgical treatments of ocular adnexa, which can prolong blepharoptosis surgery. So the way I present this to patients is because now we have a drop. we can do that. You can do it once a day. We see how it works. But if they've also got a little bit of dramatic chalasis or they've got just lax lids, then I can go in with radiofrequency and tighten things and build collagen. So how does that work? We're basically creating a wound in the dermis with the skin overlying it intact. And there's zero downtime, but by doing that, we're creating inflammation, and then your body will start to lay down collagen, and it will lay it down for about 6 months. So we'll do these treatments typically I do them by decade. So if you're 22 treatments, 33 treatments, 44 treatments, and we'll do them 4 weeks apart. And then we'll do like a maintenance treatment every 6 months so that we continue to lay down collagen. And clinical endpoints, when you do this, it takes about 25 minutes to do a full face. So I just did the right side of my face just so you could compare. But you can see, like, I mean, my eyebrow on that right side's higher, my eyelid's more open, and that cheek is definitely fuller. And they'll look like this for about 24, 48 hours. And then they'll call me on Monday and be like, what happened? What happened to my beautiful like results? Because that's the inflammation part of it. So now the body will come in and start to pick up all the old dead stuff. And then you'll start to lay down more collagen slowly over the next 6 months. There's before and after. This was a patient that was in my optical, and she's like, I can't find anything that looks good on me. And I was like, I have 1,000 frames out there. Surely there's something. And then she said, you know what? It's just my face. It's terrible. And I was like, oh my gosh, like how horrific. Like I wanted to cry. I was like, okay, so let's go back in here. We're going to have another conversation because I can help you. And, you know, and patients think that this is about, like, they feel bad at even asking because they feel like it's vanity. This is not about vanity. This is about feeling good and looking in the mirror and a reflection of what you feel like on the inside. And my husband is always my litmus test because he's an English teacher. So I had him look at my before and after, and I was like, what do you see? And he's like, well, her forehead is a lot like smoother and her eyes are more open, her eyebrows are higher. And I was like, okay, win. And you can see, like, and you won't do like deep lines, but you'll certainly soften, and you can definitely help fine lines and tighten things. And there's before and after. So let's touch on intense pulse light, because I'm sure you guys have heard tons about that in the dry eye space, right? There's a difference between lasers and IPL. So IPL is different. We're using lots of different wavelengths to treat patients. It's pulsed light therapy. Laser light is monochromatic, coherent, and parallel. So whatever wavelength that we're using, that's what will be on the handpiece. It might be a 1540 or a 1565, a 2940. A CO2 is 10,200. They are different, and they're targeting different things. IPL will target pigment, one chromophore, and hemoglobin, the other chromophore. So we're targeting telangiectatic vessels and photo damage, right? That's how we're doing that. And we're using selective photothermal lysis to target the target, but leave the skin around it intact to get the results that we want. And we want to do it in a way that heats that melanocyte or heats that blood vessel to the point that it gets destroyed, but it doesn't blow up, especially blood vessels, because the last thing you want to do is make a big bruise. So that's why selective photothermal lysis is so important. That's a whole nother lecture, and we do not have time, but I wanted to touch on that. Minimally invasive are going to be neurotoxin injections, and then non-ablative laser resurfacing. So neurotoxin came about because they were treating blepharospasm, right? And strabismus actually started in ophthalmology. And when they were doing blepharospasm, they're like, man, these wrinkles like went away. Can you make the other side of my face look like that? And Botox was born. So there's 4 different types on the market. Botox is the one that most people use. It's like Kleenex, right? Because it has such a big market share. Celeste Barber is my absolute favorite comedian. And if you don't follow her on Instagram, you should, because she takes these nonsense, ridiculous pictures that we all compare ourselves to and want to be, as do our patients, and makes fun of them and recreates them, because no one actually like does this, right? And she makes a ton of fun of the Kardashians, which I absolutely love. So just a good reminder to we're enhancing beauty, and we have unrealistic expectations. Sometimes we just want to look like a better version of ourselves, but it's a nice reminder. So neuromodulators are for dynamic wrinkles. So those are the ones you see when the face is moving. So this is one of my patients who had an injury when he was 18 and his 7th nerve was damaged. What do you see? Wrinkles on one side. What's not on the other side? Smooth. That's why Botox works so well. Because when he's not moving it, that's what makes the wrinkle. This is another patient. So we do Botox on, she had jaw surgery and they damaged her 7th nerve. So she can't move that right side. And so we smooth it out on the left side with neurotoxin. This will show up in your clinic. So about 1 in 10 of our patients, based on how many eye exams we do and how many people in the country are having injections, I went back and looked at all of that. About 1 in 10 patients is going to be having neurotoxin. It'll be more depending on your area. But this is a patient that came in for a glasses recheck. And I looked at the thing and I was like, she got her glasses like 4 months ago. Why is she just now having a problem with her glasses? And so I'm looking at her history and she's got chronic migraines. And I was like, when did this start? And she's like, oh, about 3 weeks ago. And I was like, what else happened about, a month before that? And she's like, oh, I got Botox for my migraines. I was like, oh. So what you notice about her face is her forehead is teeny tiny, like one finger width of forehead. I have like 5 foreheads, right? Like there's a lot of real estate up here to do some things with. And when they do migraines, they do a lot of units of Botox. It's like 120 units and they do it right in the hairline all the way around. So when they did that, because her forehead's so tiny, the only elevator in our forehead is the frontalis. So that's why Dr. Zamara was talking about when you want to evaluate what's happening with the brow, you push that so you can't move it because it will move up because the frontalis is pulling this up, right? This is her looking up as hard as she possibly can. It's totally frozen. So I leaned over with her glasses on and I pulled it up and I was like, do you see better now? Can you see the chart? And she's like, oh my gosh, it's so much better. What'd you do? And I was like, oh, it's just the Botox. I was like, it'll wear off in 90 days. She was all freaked out. But just, this is the kind of stuff that will show up in your clinic, but you would have spun your wheels refracting her, trying to figure out what was happening if we didn't know that history. This is another patient. He did come in. I rarely have patients that come in saying, hey, I need a brow lift or I need a bleph, but he said, I need an eyebrow lift. And I was like, well, let's talk about how much Botox you're putting in your forehead first. And he was like horrified and shocked. He's like, oh my gosh, can you tell? I was like, yes. Let's go a little lighter and stay high, because what happens when you depress an elevator, you get more depression. Like when you paralyze an elevator, you get depression. So they dropped his brow because we had too much going on up top. So we talked about IPL, we talked about laser, we talked about radiofrequency. So how does IPL actually work? What is it doing? This is a great study to think about around meibomian gland dysfunction. Came out in 2017. And I like this acronym: bugs, enzymes, inflammation, stasis, temperature, and obstruction. Any one of those will cause meibomian gland dysfunction, or we might have all 6. IPL tackles all 6 of those, which is what's really cool about it. Can you still treat all 6 with other modalities? Absolutely. You can do it with, a combination. You could do cyclosporin and hypochlorous acid and a good omega-3 and get all 6. So there's ways to get there. It's just IPL does it all at once. And if they have rosacea, we're targeting, what are we targeting with IPL? I know it's late in the day. There's been mimosas and spritzes, reds and browns, right? Thank you. Hemoglobin, you get an extra spritz. We're targeting that so that we are doing photocoagulation, photoimmunomodulation, photomodulation, photothermolysis, and one more fun thing about Demodex. So the little exoskeletons of Demodex happen to uptake light at the very same wavelength that pigment does. So when we do that flash with the IPL, they're barbecued. So fun times there. But you can get some really amazing results. So this is one of my patients that has rosacea. She has meibomian gland dysfunction. When you have rosacea, it is a much worse prognosis. It's harder to treat their MGD. So I treat their rosacea as well as their MGD. And this was after just one treatment. I mean, you can see and she's like, her self-confidence, just everything about her, she walks about a mile higher. It's really cool. And you can also treat chalazia non-invasively, right? Because most of my patients do not want me to put a needle in there with Kenalog, and they sure don't want me to put a blade in there and do an INC. And so chalazia management is another way to use IPL. If we're doing laser and we're doing skin resurfacing, because this skin out here is really thin, and the orbicularis oculi, when we're talking about neurotoxin, be careful in that space and be careful when your patients are doing it there, because what happens when you paralyze a depressor, it doesn't close all the way. And so you mess with their blink reflex. But this stubborn, crepey skin is beautifully resurfaced with laser. And we're targeting water, basically. So, you know, depending on where we are in the skin, a 1540 is going to be non-ablative, meaning we're leaving skin intact. And ablative laser means that we take off and vaporize everything in its path. So at 10,000, you know, 200 CO2 gives people a second, third degree burn, basically. They can't leave the house for 2 weeks wrapped in aquaphor because they are high risk to get an infection when you don't have any skin on there. High risk, high reward. It looks amazing, but they can have redness for up to 3 months. They can get hyperpigmentation. And so a lot of people have moved to non-ablative procedures or ablative that's fractionated, meaning you leave little wounds intact between the columns of ablation that you create, but you get some really good results. Patients will ask you about this. Before and afters. So I put this on here because this is a clinical endpoint and you can see exactly where her goggles were. So I had to go back and retreat on that right outside edge, but I wanted you to see endpoints. And then ablative, resurfacing, and then surgical procedures, what Dr. Zamora covered very beautifully earlier. How many people in here co-manage cataract surgery? How many people in here co-manage their oculoplastic surgery? So I would love for us, when I come back, and hopefully I'll be invited back at some point, that we have more hands that are closer to the cataract post-op than as we do the bleph and the oculoplastics, because we are seeing these patients all day, every day. They need our help. We have this skill set. We can co-manage with our oculoplastic surgeons just like we do our cataract surgeons. We've talked about blepharoptosis. I use Upneek. This is my patient. You can see dramatically on that right eye how much more open she is and how much whiter her eye is as well. So I love that this is part of our conversation now. Dark circles is a whole different topic. It's in your handouts because these are really hard to manage. So this is a paper that's about 20 pages long and it's amazing. So I put it in here so you guys would have a reference. The way that I have incorporated aesthetics into my practice, and I struggled with this a little bit when I first started. I was like, how do I bring this up where I'm not like offending people? Hey, don't you want to do something about those lines between your eyes? Probably not a good way, not a good patient builder, right? And so I struggled with that, but I have developed this questionnaire and it's worked amazingly well. So it's got dry eye questions, it's got sleep apnea questions, rosacea questions. And by the way, when it says on here, does your face flush easily eating spicy foods? Make sure you put face or skin in there, because my first version did not have that. And it said, do you flush after eating certain foods? That survey lasted until about noon. And my director of first impressions marched back and she you know, stuck it on my desk and she's like, this is a problem. And I was like, what is happening? And she's like, do you read it? And I was like, yeah, it says, do you flush after eating certain foods? I'm wondering about rosacea. And she's like, read it again. And I was like, and I still didn't get it. And then she's like, Selina. And I was like, oh, okay. Words matter. And then I've got retina questions up top, and then this external exam with a little picture of before and after of Upneek that says, would you like your eyes to be more open? And then, you know, questions around, are there areas around your eyes that you would like to change or enhance, such as, and gave them pictures. So when they answer yes to those, we have an opportunity to start that conversation in a really easy way. So lots of fun things. Thank you guys.